Pancreatic cancer is one of the most serious diagnoses a person can receive, and it carries a particularly grave prognosis not because it is inherently untreatable, but because it is almost universally caught late. The 5-year survival rate for pancreatic cancer detected at stage 1, when the tumor is still confined to the pancreas, reaches approximately 37 to 44%, according to data published in CA, a cancer journal for clinicians. But fewer than 20% of cases are diagnosed at that early stage. By stage 4, when cancer has spread to distant organs, that survival rate drops below 3%. This is not a failure of medicine alone. It is, in large part, a failure of awareness. The pancreas is a deep retroperitoneal organ. It sits tucked behind the stomach, in front of the spine, largely invisible to the body's own pain signaling systems until a tumor has grown large enough to compress surrounding structures. This anatomical reality means that by the time most people feel something is wrong, the disease has already had months, sometimes years, to progress silently. What this video is about is closing that gap. Over the next several minutes, we are going to go through 8 symptoms that research has identified as early or overlooked warning signs of pancreatic cancer. For each one, we will explain what is happening biologically, why the pancreas produces this symptom, what cellular and structural mechanisms are at work, so that you understand not just what to watch for, but why it matters. This is not a list of vague warnings. This is a mechanistic explanation designed to help you take these signs seriously when you or someone you love experiences them. One critical note before we begin: none of what follows is a substitute for clinical evaluation. If you recognize any of these symptoms in yourself, the correct response is to speak with your physician and request appropriate imaging. Most commonly a CT scan with contrast, an MRI, or an endoscopic ultrasound. Early detection is the single most powerful tool available against this disease, and that detection happens in a clinical setting, not from a video. With that foundation established, let us begin. Symptom number 1, jaundice, the yellowing that is not always obvious. Jaundice refers to the yellowing of the skin and the whites of the eyes caused by the accumulation of bilirubin in the bloodstream. Bilirubin is a yellow-orange pigment produced during the normal breakdown of red blood cells. Under healthy conditions, bilirubin is processed by the liver, conjugated into a water-soluble form, secreted into bile, and transported through the bile duct into the small intestine, where it is eventually excreted. When this pathway is disrupted, bilirubin accumulates, and the body literally changes color. The head of the pancreas, the rightmost portion of the gland, sits directly adjacent to the common bile duct, the tube that carries bile from the liver and gallbladder into the small intestine. When a tumor develops in the head of the pancreas, it frequently compresses or invades this duct, physically blocking the flow of bile in what clinicians call obstructive jaundice. This is distinct from hepatic jaundice, which originates from liver disease, or hemolytic jaundice caused by excessive red blood cell destruction. In obstructive jaundice from a pancreatic tumor, the liver continues to function, but bile has nowhere to go. Conjugated bilirubin backs up into the bloodstream and deposits in skin and scleral tissue. Research published in Gut, the British Society of Gastroenterology's journal, found that painless jaundice without accompanying abdominal pain, was the presenting symptom in approximately 50 to 70% of pancreatic head cancers. The word painless is critical here because most people associate jaundice with discomfort. When it appears without pain, the instinct to seek care can be delayed. That delay is dangerous. What should you look for specifically? The first visible sign is usually yellowing of the whites of the eyes, what clinicians call scleral icterus, often noticeable before the skin changes color at all. As bilirubin levels continue to rise, the skin itself takes on a yellowish tone, most visible on the palms or in natural light. Urine darkens to a deep amber or tea color, because bilirubin is water-soluble and is excreted renally when serum levels become elevated. Stools turn pale, gray or clay-colored, because bile is what gives stool its normal brown pigmentation, and when the bile duct is obstructed, that pigmentation disappears. Finally, Many people with jaundice experience intense itching of the skin caused by bile salts depositing in cutaneous tissue and stimulating nerve endings. It is worth emphasizing that jaundice has benign causes. Gallstones are a common culprit, but in an adult over 60 with no prior history of gallstone disease, new-onset painless jaundice should be treated as a potential malignancy until imaging proves otherwise. Guidelines from the American College of Gastroenterology recommend urgent imaging, typically within 2 weeks, for any adult presenting with new jaundice of unclear cause. Do not wait for pain. Painlessness is a feature of this symptom, not a source of reassurance. Symptom number 2, upper abdominal or back pain that worsens when lying down. Abdominal pain is one of the most common complaints in all of medicine, associated with hundreds of conditions ranging from the trivial to the life-threatening. What distinguishes pancreatic cancer pain from the more familiar discomforts of gas, indigestion, or muscle strain is its character, its location, and, most distinctively, its positional behavior. The pancreas is innervated by the celiac plexus, a dense network of autonomic nerve fibers that surrounds the celiac artery near the upper abdomen. As a pancreatic tumor enlarges, it can infiltrate or compress these nerve fibers, producing visceral pain that is typically described as a dull, deep ache in the upper abdomen or mid-back. This pain often has a boring or gnawing quality, persistent rather than colicky, present at rest, and resistant to the usual remedies. The positional component is one of the most clinically useful distinguishing features. In the supine position, lying flat on the back, the retroperitoneal tumor is pressed against the spine and surrounding structures by the weight of abdominal organs. Leaning forward, sitting hunched over, or curling into a fetal position temporarily relieves this pressure. People with pancreatic cancer will often unconsciously adopt these postures, especially when trying to sleep, without understanding why. A landmark study in JAMA examining symptom patterns across pancreatic cancer patients found that new-onset back pain, particularly in combination with weight loss, was one of the symptom clusters most strongly associated with delayed diagnosis. Patients and clinicians frequently attributed it to musculoskeletal causes, a pulled muscle, degenerative disc disease, arthritis. Abdominal imaging was not ordered. The cancer continued to grow. The features that should raise concern are pain centered in the upper abdomen, often radiating to the mid-back or between the shoulder blades. Pain that is dull and continuous rather than sharp and episodic. Pain that specifically improves when leaning forward and worsens when lying flat. Pain that wakes you from sleep. And pain that is not clearly related to physical activity or posture in the way a musculoskeletal injury would be. None of these features in isolation confirm anything, but their combination, particularly in an older adult with no prior back pathology or a recent significant injury, should prompt abdominal imaging, not simply reassurance and physical therapy. Symptom number 3, unexplained weight loss and muscle wasting. Weight loss is perhaps the most nonspecific symptom in all of oncology. Nearly every cancer can produce it, and so can thyroid disease, depression, chronic infection, and many other conditions. But the rate, character, and accompanying features of weight loss in pancreatic cancer are distinctive enough to warrant specific attention. Pancreatic cancer drives weight loss through 2 distinct and compounding biological pathways, and understanding both of them is important. The first is cancer cachexia. Advanced malignancies, and pancreatic cancer in particular, trigger a systemic inflammatory response characterized by markedly elevated levels of pro-inflammatory cytokines, including tumor necrosis factor alpha, interleukin-6, and interleukin-1. These molecules disrupt normal metabolic signaling at multiple levels simultaneously. They suppress appetite through direct action on hypothalamic feeding centers, reducing the drive to eat. They accelerate muscle protein catabolism through the ubiquitin proteasome degradation system, the cellular machinery that tags and destroys proteins so that skeletal muscle is broken down for fuel even when other energy sources are available. They promote lipolysis in adipose tissue, depleting fat stores. The result is a form of wasting that cannot be reversed by simply eating more. because the metabolic machinery has been fundamentally reprogrammed by the tumor's inflammatory environment. Research published in Nature Reviews Cancer described pancreatic cancer cachexia as among the most aggressive in all of oncology. The second pathway is exocrine pancreatic insufficiency. The pancreas is the body's primary manufacturer of digestive enzymes. Lipase breaks down dietary fats. Amylase breaks down carbohydrates. Proteases break down proteins. A tumor that invades or obstructs the pancreatic duct, the main channel through which these enzymes travel to the small intestine, can reduce enzyme secretion dramatically. Without adequate lipase, fat passes through the gut largely undigested and unabsorbed. Without adequate protease, protein absorption is impaired. Caloric extraction from food drops substantially even when a person appears to be eating normally. The result is malnutrition and progressive weight loss that occurs even with maintained dietary intake. What this means practically is that weight loss driven by pancreatic cancer is often accompanied by additional signs, persistent bloating or fullness after small meals, changes in stool character that we will discuss in a moment, and fatigue and weakness that goes beyond what the weight loss alone would explain. Any unintentional loss of more than 5% of body weight over 6 to 12 months without a deliberate dietary change demands medical investigation. In an older adult, this should never be attributed to aging without ruling out an underlying pathology first. Symptom number 4, new onset diabetes in older adults. The development of type 2 diabetes in an older adult who had no prior blood sugar problems is not, by itself, an unusual event. Type 2 diabetes is prevalent, and risk does increase with age. But emerging research has revealed a specific and alarming connection between newly diagnosed diabetes and pancreatic cancer that has fundamentally changed how some clinicians view this common diagnosis. The pancreas serves two major biological roles. Its exocrine function, the production of digestive enzymes, is what we discussed in the previous section. Its endocrine function is the production of hormones, most critically insulin, which is secreted by the beta cells of the islets of Langerhans scattered throughout the pancreatic tissue. A growing tumor can destroy or displace islet tissue, impairing insulin secretion and raising blood glucose. But something more specific than simple tissue destruction appears to be happening. Researchers have identified that pancreatic tumors produce substances, including a protein called adrenomedulin, that selectively impair beta cell function and induce insulin resistance in surrounding tissue. This means the diabetes may not be merely a consequence of destroyed pancreatic tissue. It may be an active metabolic product of the tumor itself, a biological signal the cancer is emitting that manifests as a change in blood sugar regulation before any other symptom appears. A large-scale study published in Gastroenterology examined over 2,000 patients with newly diagnosed pancreatic cancer and found that approximately 40% had been diagnosed with new-onset diabetes in the preceding 36 months. The median time between the diabetes diagnosis and the cancer detection was 6 to 12 months. In a subset of patients who underwent successful surgical removal of the tumor, the diabetes resolved, confirming the causal relationship. The clinical signal that should raise concern is not diabetes itself, but diabetes with specific characteristics. The onset is rapid in an adult with no prior prediabetes or known metabolic risk factors. It is accompanied by significant weight loss, which is the opposite of what typically accompanies type 2 diabetes, where weight gain is more common. Blood glucose is difficult to control despite appropriate intervention, and the usual features of metabolic syndrome, obesity, hypertension, high triglycerides, are absent. If you or a family member develops diabetes after age 60, particularly with these atypical features, it is entirely reasonable to ask your physician whether pancreatic imaging is warranted. The American Diabetes Association now acknowledges this association in its clinical guidelines. Symptom number 5, changes in stool, floating, pale, and oily. The characteristics of stool are among the most reliable and yet most underutilized indicators of gastrointestinal health. Most people do not examine their stools carefully, and clinicians often do not ask in detail. But specific changes in color, consistency, buoyancy, and odor can reflect profound disruption of the digestive process, including the failure of pancreatic enzyme secretion. When the pancreatic duct is obstructed by a tumor, or when pancreatic tissue itself is destroyed by the cancer, the secretion of lipase into the small intestine drops substantially. Lipase is responsible for emulsifying dietary fats, breaking triglycerides down into fatty acids and monoglycerides that can be absorbed through the intestinal wall and enter the circulation. Without lipase, dietary fat passes through the gastrointestinal tract essentially intact. In the colon, this unabsorbed fat creates a series of characteristic changes. Stools become pale, gray, or clay-colored because bile pigments, the substances that give stool its normal brown color, are also absent when the bile duct is obstructed. Stools develop a greasy or oily texture. They float persistently in toilet water because their high fat content makes them buoyant. They have a dramatically intensified foul odor caused by bacterial fermentation of the undigested lipids. This combination of features is called steatorrhea, a clinical term for fat in the stool, and it is a direct indicator of exocrine pancreatic insufficiency. One important fact about steatorrhea, published research in the journal Pancreatology estimates that visible steatorrhea does not become clinically apparent until more than 90% of pancreatic exocrine function has already been lost. This means that by the time someone notices these changes in their stool, the level of pancreatic disruption is already severe. This is another reason why waiting for dramatic or obvious symptoms leads to late diagnosis. The specific things to observe are stools that float and are difficult to flush, stools that are pale, gray, or clay-colored, particularly if accompanied by jaundice, an oily sheen or visible oil droplets in the toilet water, and a markedly increased foul odor beyond what is normal. Diarrhea that is greasy or loose in character rather than watery can also indicate fat malabsorption. Pale stools without jaundice may indicate gallbladder or bile duct pathology of other types. With jaundice, they form one of the most urgent symptom combinations on this list. Symptom number 6. Nausea, loss of appetite, and the sensation of being full after only a few bites. Nausea and reduced appetite are deeply common among older adults and can result from hundreds of causes: medication side effects, anxiety, other illnesses, gastroparesis. In isolation, they are nonspecific. But the mechanisms through which pancreatic cancer produces these symptoms are worth understanding, because they explain why these complaints can be so persistent and so resistant to the usual remedies. 3 distinct biological mechanisms operate simultaneously in pancreatic cancer to suppress appetite and produce nausea. The first is mechanical, gastric outlet and duodenal compression. The head of the pancreas sits immediately adjacent to the duodenum, the first segment of the small intestine through which food exits the stomach. A tumor growing in this region can physically compress or partially obstruct this passage, slowing gastric emptying and producing early satiety, the sensation of being completely full after only a few bites of food, along with nausea, bloating, and in some cases vomiting. The second is biochemical, cytokine-mediated appetite suppression. The same pro-inflammatory cytokines involved in cachexia, tumor necrosis factor alpha and interleukin-6, act directly on the hypothalamus, the brain region that regulates hunger and satiety. They suppress the activity of ghrelin, the stomach-derived hormone that drives appetite, and amplify leptin signaling, which promotes the sensation of fullness. The result is genuine biological anorexia, not a loss of interest in food for psychological reasons, but a suppression of appetite at the hormonal and neurological level. The third is biliary. Bile reflux and digestive disruption, obstruction of the biliary system, can cause bile to reflux into the stomach, creating persistent nausea, a bitter taste in the mouth, and a general sense of upper gastrointestinal discomfort that is difficult to characterize precisely. The pattern that should prompt attention is a sudden or progressive decline in appetite without a clear cause, feeling uncomfortably full after eating only a small portion of a normal meal, persistent nausea not associated with medications, motion, or acute illness. and an aversion to fatty or rich foods that were previously well tolerated. When these symptoms appear alongside weight loss and any of the other features described in this video, the threshold for investigation should be low. Symptom number 7. Blood clots, deep vein thrombosis, and pulmonary embolism. A blood clot developing in the deep veins of the leg, known as deep vein thrombosis, or breaking off and traveling to the lungs, known as pulmonary embolism, is a medical emergency in its own right. What many people do not know is that unprovoked blood clots, meaning clots that occur without an obvious trigger such as surgery, immobility, prolonged travel, or known clotting disorder, are significantly associated with hidden malignancy. Pancreatic cancer is among the most thrombogenic cancers in existence, meaning it has an unusually strong tendency to promote clot formation. Multiple distinct biological mechanisms are responsible for this. The first is tissue factor overexpression. Pancreatic tumors overexpress tissue factor, a cell surface protein that triggers the extrinsic coagulation cascade, the sequence of enzymatic reactions that ultimately converts fibrinogen to fibrin and forms a solid blood clot. Circulating tumor cells shed tissue factor into the bloodstream, creating a hypercoagulable state throughout the body, not just at the tumor site. The second is mucin secretion. Pancreatic ductal adenocarcinoma, the most common type of pancreatic cancer, secretes large quantities of mucins, heavily glycosylated proteins that can directly activate platelets and initiate clot formation through pathways entirely independent of the normal coagulation cascade. The third is vascular compression. Tumors located near the portal vein or the superior mesenteric vein can physically compress these major vessels, slowing blood flow and creating conditions favorable to thrombosis through the mechanism of venous stasis. The relationship between visceral cancer and migratory thrombophlebitis was formally described in the 19th century by the French physician Armand Trousseau, who identified the syndrome in himself and subsequently died of gastric cancer. Trousseau's syndrome, recurrent migratory superficial thrombophlebitis associated with occult malignancy, remains a recognized clinical entity today. A large prospective study published in the New England Journal of Medicine found that among patients with unprovoked deep vein thrombosis or pulmonary embolism with no identifiable risk factors, approximately 10% were subsequently diagnosed with an occult malignancy within 12 months. Gastrointestinal and pancreatic cancers were among the most common types identified. The warning signs that warrant urgent evaluation are swelling, redness, warmth, or pain in one leg, particularly the calf or thigh, without an obvious cause, unexplained shortness of breath, chest pain, or a rapid heart rate, and any first blood clot in a person over 60 with no prior clotting history and no clear precipitating event. Any unprovoked clot in an older adult should prompt your physician to consider whether a malignancy workup, including abdominal imaging, is appropriate. Multiple major hematology and oncology societies now recommend this as a standard consideration. Symptom number 8, new onset depression or significant mood changes. This final symptom may be the most surprising on this list, and it carries some of the most fascinating and counterintuitive biology. Depression is extraordinarily common, affecting many millions of older adults for reasons that have nothing to do with cancer, but a specific pattern of new onset depression or significant mood change preceding a pancreatic cancer diagnosis has been documented consistently in the scientific literature, and it deserves careful attention. For decades, the depression associated with pancreatic cancer was attributed to a straightforward psychological mechanism. A person learning of a serious, life-threatening diagnosis naturally experiences profound emotional distress, but the pattern observed in the research does not support this as the primary explanation. The mood changes frequently precede the formal cancer diagnosis by months, sometimes by more than a year. Patients described the onset of depression before they had any physical symptoms that led to a doctor's visit, before any imaging was ordered, before they had any reason to suspect what was coming. This timeline strongly implies a biological rather than purely psychological origin. Two mechanisms have been proposed and investigated. The first involves serotonin pathway disruption. The pancreas plays a more significant role in serotonin metabolism than is commonly appreciated. Pancreatic tumors can disrupt local serotonin signaling, and alterations in gut-derived serotonin, which plays a substantial role in mood regulation through the gut-brain axis, may contribute to depressive symptoms that emerge before any structural symptoms appear. The second involves cytokine-mediated neuroinflammation. The pro-inflammatory cytokine cascade generated by the tumor does not remain confined to the abdomen. Tumor necrosis factor alpha and interleukin-6 cross the blood-brain barrier and act on the central nervous system, where they suppress dopaminergic and serotonergic signaling, activate the hypothalamic pituitary adrenal stress axis, and produce what neuropsychiatrists call sickness behavior, a constellation of fatigue, social withdrawal, anhedonia, loss of pleasure in previously enjoyable activities, and low mood. This cytokine-driven neuroinflammation may be generating genuine biological depression as an early systemic effect of the tumor, months before the cancer becomes physically apparent. A study published in Psychosomatic Medicine that followed over 4,000 patients found that individuals with pancreatic cancer were significantly more likely to have received a depression diagnosis in the 12 to 18 months preceding their cancer detection compared to patients with other gastrointestinal malignancies, a difference that persisted even after controlling for known psychological and social risk factors. To be clear, the vast majority of depression in older adults is not caused by cancer. This symptom, more than any other on this list, must be understood in context. But when new-onset depression appears alongside unexplained weight loss, gastrointestinal changes, upper abdominal pain, or any other features described in this video, the possibility of an underlying organic cause, including pancreatic pathology, should not be dismissed without investigation. Each of the 8 symptoms we have discussed, painless jaundice, positional back and abdominal pain, unexplained weight loss and muscle wasting, new-onset diabetes in older adults, changes in stool character, nausea and early satiety, unprovoked blood clots, and new-onset depression, has multiple possible causes. Most people who experience any one of them will not have pancreatic cancer, but most people who develop pancreatic cancer will experience some combination of them, and the window during which that combination can lead to early detection and potentially curative treatment is narrow. The 5-year survival rate when pancreatic cancer is found at stage 1 is 37 to 44%. By stage 4, it is below 3%. That gap is not primarily a gap in treatment. It is a gap in awareness, in recognition, and in the willingness to investigate symptoms that could be explained away by something less serious. If you recognize any of these symptoms in yourself or in someone you care about, speak with your physician. Ask specifically about imaging. Ask about a CT scan with pancreatic protocol or an MRI. Or an endoscopic ultrasound if there is reason for concern. Bring this information with you. Advocate clearly and directly for evaluation. The pancreas is a silent organ in the best of times. These 8 symptoms are among the few signals it sends when something has gone wrong. None of them should be ignored.